Thank you for joining our Debbie Stream Foundation webinar series. Today's webinar features Dr. Vivian Strong, who will give us a presentation on surgical options and neoadjuvant chemo for locally advanced stage gastric cancer patients. I'm Brittany Starks, Communications Director for Debbie Stream Foundation, and I will be moderating today's webinar. Thank you to our generous sponsors for making today's program possible. Title sponsors Amgen, Astellas, Daiichi Sankyo, and Merck, and silver sponsors Bristol Myers Squibb and Lilly Oncology. First, I'll share information about stomach cancer and Debbie Stream Foundation. Then we will hear a presentation on surgical options and neoadjuvant chemo for locally advanced stage gastric cancer patients with Dr. Vivian Strong. A Q&A session will follow the presentation. You can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions at the conclusion of the presentation as time allows. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is the second leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate between 20% and 30%, depending on the country. Many patients are asymptomatic during early stages of stomach cancer, leading to late diagnosis. Debbie Stream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiestream.org. Pictured here is Debbie Zellman, the founder of Debbie Stream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in April of 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many recurrences. Unfortunately, Debbie passed away on December 23, 2017, at the age of 50 after a 9.5-year battle with cancer. As an organization, DDF continues her important work and legacy. In a few short years, DDF has achieved many great milestones. We have 32 chapters across the US, including Canada and Germany. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We have also provided $1.45 million in research grants to date. Each year, patient advocates come together at our annual Stomach Cancer Capitol Hill Advocacy Day to secure funding from the Department of Defense's peer-reviewed cancer research program. This program allocates funds for stomach cancer research. Earlier this month, we traveled to Washington, D.C. with more than 130 advocates and held 180 meetings with lawmakers to inform them that we need more funding for this deadly disease. We're proud to say that this year was our largest turnout yet. We hope you'll join us next year as we let Congress know we need a cure. We will now begin the presentation on surgical options and neoadjuvant chemo for locally advanced stage gastric cancer patients with Dr. Vivian Strong. Dr. Strong is Vice Chair in the Department of Surgery for Surgical Innovations and Outcomes, and she holds the Iris Cantor Endowed Chair at Memorial Sloan Kettering Cancer Center. She's Professor of Surgery and Associate Dean at Weill Medical College of Cornell University. She specializes in the management of patients with gastric cancer and has authored over 150 publications and over 25 book chapters and edited several textbooks. Dr. Strong received her MD degree with honors at Weill Medical College of Cornell University and completed her residency training at New York Hospital in Cornell. She also completed an advanced can't say this word, laparoscopic fellowship at Cornell and Columbia University before joining the staff at Memorial Sloan Kettering Cancer Center in 2005. She's performed over 1,000 gastrectomies and over 500 robotic gastrectomies, making this the largest experience in the US. Dr. Strong, I will now turn the presentation over to you.
All right, thank you so much. And Debbie, can you see me and can you hear me all right?
Yes.
Okay, great. Thank you, Brittany. First of all, it's such a pleasure to be here today at Debbie's Dream Foundation, hearing just about the remarkable progress that has been made in this organization. All of us in the stomach cancer world are familiar with Debbie's Dream Foundation and are very grateful for the advocacy for this important disease. So it really is just such a pleasure to be able to speak to all of you today. And I'm hoping that this will be a helpful presentation, which I have geared mostly for the patient level, in order to really demystify some of the processes and ways that we use to approach gastric cancer treatment for our patients. So today, what I was hoping to talk about is the surgical approach to locally advanced gastric cancer. So what that basically means is gastric cancers that require more than just surgery. As you all know, without an operation, gastric cancer cannot be cured. However, in cases where it's anything except the very earliest stages, which is most of the cases that we see, you need more than just surgery alone. You need combinations of chemo, or radiation therapy or immunotherapy. So that can be kind of confusing. So that's what I hope to cover. Let me just make sure I can advance my slides. So as Brittany also already mentioned, but I'd like to highlight, gastric cancer is a global health concern. And in fact, worldwide, there are over 1 million new cases diagnosed annually. And that makes worldwide, gastric cancer is the 5th most common cancer and the 3rd most common cause of cancer deaths. And that's really just unacceptable. I know Debbie's Dream Foundation feels that way, as we do also, but we need to change that. One of the issues is that in the United States, many people say, well, gastric cancer is something that isn't so much of a problem anymore. We know that's not true, but that is the general impression. And it largely comes based on maps like this, which show the incidence of stomach cancer varied by region of the world. Excuse me. And you can see that especially in China, in Russia, in Japan, Korea, so forth, the incidence of stomach cancer is extremely high. There are a lot of reasons for that, which we can't cover today, but it's an interesting area of study for me to look at what those differences are. But nevertheless, the incidence of stomach cancer in other parts of the world are real. You can see even in South America here, Chile has an incidence of stomach cancer that rivals that of China and Japan and Korea, some countries in Central America as well. But in the United States, those numbers are also real and rising. This historic thing that we talked about really was because in the early 1900s, stomach cancer was actually the #1 cause of cancer deaths in the United States. And as you can see here, there's this light green line here. And what happened is the reason stomach cancer rates dropped so quickly is because there was a change in the way that we processed food, refrigeration, and there was an awareness of H. pylori infection as being an important cause of a certain type of stomach cancer, the H. pylori-related type of stomach cancer. So once the FDA decided to come into existence around this time and refrigeration and preservatives became a thing, these numbers dropped. But that now has changed. The U.S. gastric cancer statistics, specifically, about 26,000 new cases, and half of those patients in the United States, and that's up from 24,000 cases in 2011. So the numbers continue to grow. Unfortunately, because we have no mandated screening programs like we do, for example, for colon cancer, we usually find these cancers in a later stage, and it's very hard to treat and cure if it's in any, the earlier we catch it, the better. And that reason of finding it at a later stage is why we see an increased incidence of death. Many patients we can't cure because we're finding it too late. So we need to change that. You might say, well, why is this happening, and is it only in the United States? No, it's not. In fact, if you look at statistics from South Korea, and if you look at statistics from Japan, you can see that the incidence of stomach cancer continues to rise in these countries as well. And remember, they have excellent screening programs in these countries, and they find the cancers more often at an early stage. But there are lots of theories for this. In Japan, one interesting paper said that they think as the population gets older, that's causing more stomach cancers. But I don't think that explains it completely. When you think about colon cancer, for example, the recommendations for getting your first colonoscopy used to be 50. Now it's dropped to 45 because there's an increased incidence of colon cancer. You think about all the GI tract cancers, and I think that it's very interesting that gastric, colon cancer, all esophageal cancer, they're all increasing. And we have to wonder, are there environmental causes? So if you look specifically at what numbers are increasing, you can see that for non-cardiac gastric cancers, so these are the ones that happen not in the main part of the stomach, sorry. Yeah, there we go. The ones that don't happen up here, the ones that happen up at the GE junction or the top of the stomach where I'm pointing here, those are the kind of cancers that typically are more related to reflux disease, to people who have obesity and therefore have a lot of injury and kind of reflux to that part of the stomach and bottom of the esophagus. But non-cardiac gastric cancers, those that happen in the main part of the stomach, that's not related to reflux, that's not related to obesity, and those numbers have been increasing in young people under the age of 40. In fact, the statistics in this very well done article from a few years ago said that there is a 70% increase in the incidence of these non-cardiac gastric cancers just in the United States. I mean, it's crazy. So we do know that there is a real need. The GE junction cancers, like we talked about, these are the ones that happen at the top of the stomach. These make a bit more sense as, our population has an obesity epidemic as well, and there are more of these cancers found. I think that's partly explained by those factors. So one thing that I really like for people to understand is that stomach cancer is really not just one type of disease. People say, oh, I have stomach cancer. The first question that surgeons or medical oncologists like us will ask is, what type of stomach cancer? And they really are different types that have a different prognosis, different idealized treatment paths. And our program hypothesized this early in the early 2000s, that at least 3 different clinical diseases are described by this general word we use as gastric cancer. And it's this clinical GE junction cancer that we talked about, obesity and reflux, the distal intestinal type cancers, the ones that are associated with ulcer disease, or for example, with infections like H. pylori infection that still exists today, even despite refrigeration and so forth. And then this other type, the diffuse gastric cancer. Many of you have heard about this. This is one of the most ominous types of stomach cancer. We don't really know of any reason that this happens unless you have this special genetic mutation, which can be tested for. And we'll get into that a little bit later in the talk. But nevertheless, these clinical subtypes is something that we had noticed early on in our investigations. And one of our medical oncologists, pictured here, actually demonstrated that molecularly, at the molecular level, these 3 clinical subtypes are distinct. You have these very distinct profiles. So if we're talking about not one disease, but at least 3 different types of diseases, you have to wonder about better individualized approaches to these in order to have a good outcome for any patient who has to go through this. The whole landscape of gastric cancer became even more complicated when this big paper from the Cancer Genome Atlas Project was published in Nature, which is one of our biggest, one of our most respected journals in 2014. And they said that not only are there 3 types of stomach cancer, this GE junction, this distal type, and this other very bad type that happens in the body of the stomach, but molecularly, it's even more complicated. So some of you might have heard your doctors talking about EBV type gastric cancers, MSI type gastric cancers, the genomically stable and the chromosomally unstable, that instability group. And why is that important? If we know that there is a molecular difference in these cancers, we do now have targets that can better treat. So especially for patients who have immunogenic cancers, so gastric cancers that are EBV or MSI high, these patients benefit from immunotherapy. And there are studies that are looking at ways we can give it after surgery. Many studies are looking at whether or not we can start giving immunotherapy before surgery. And this has really changed the landscape for a subset of people who express this specific type of stomach cancer. We still have more work to do in these 2 types, especially the genomically stable, which is the one associated with the diffuse gastric cancer. So I know I'm going a bit into the weeds here, but I think it's important to understand all of these subtypes so that you have a good understanding of what kind of cancer you have and why it is that we're so interested in these specific questions and why it applies to helping with treatment. The other thing that patients will frequently ask me is, what about lymphadenectomy? Will you do a D2 lymphadenectomy? And I think that it's something that you probably read about or Google about, but most people are not really familiar with what a lymphadenectomy is exactly or what it means. So this diagram here is just to help show you that when you have a stomach cancer, it starts in the stomach. And if we can get it while it's still contained and hasn't spread, that's the best situation. That's early. But as soon as it grows or becomes a little bit more invasive, it starts to go to these lymph nodes. And lymph nodes, I'll show you a picture of them a little later in the talk, that travel first to the area that just surrounds the stomach. So this is what we would call a D1 lymphadenectomy. And this is the Japanese classification. They give it numbers, these level 1, 3, 5 lymph nodes, 2, 4, 6. It just means lymph nodes that are draining the cancer cells that surround the area of the stomach directly. That's the basic level for a good stomach operation. But we do know that a D2 lymphadenectomy is the standard of care, and that's what we advocate for almost all of our patients, unless they have a very early cancer where it's not needed. And that D2 lymphadenectomy means also removing lymph nodes that the cancer can spread to that go around some of these blood vessels that are right behind the stomach or between the stomach and the spleen right here. And so that's another aspect to doing a good cancer operation for people who can have an operation for their stomach cancer. I also think it's helpful to look at the staging. So many people get a bit confused. Stomach cancer is a very laborious process in terms of getting staging completed. And patients will come in and just say, just take it out, just bring me right to surgery. But it is really important for us to stage the cancer properly. So I show you this staging practice, the way we do it at Memorial Sloan Kettering Cancer Center. And the most important thing for us to start is determining if it's an early stage or a middle stage stomach cancer. Typically, if it's later stage, the medical oncologist would be seeing you to slow down the cancer. But if it's what we think is resectable and curable, either early stage or middle stage stomach cancers are potentially curable cancers. For early stage, CAT scans are always needed. The endoscopy is needed, but then typically we talk about doing another endoscopy, a special type with endoscopic ultrasound. And the reason that we do this is because if it's in fact an early enough gastric cancer for some lucky few people, where this is found incidentally and very early, There might even be an option to scoop out the cancer endoscopically, where they basically do what's called an ESD, or endoscopic submucosal dissection, and you scoop out the cancer. If it's anything but the very earliest stage, then a gastrectomy is recommended, because we know that even for an early cancer that has just started to go a little bit deeper in the wall of the stomach, the lymph nodes need to be sampled, because if they're positive, we're going to recommend additional treatment, which means chemo, in order to give you the best chance of cure. If someone has a middle stage tumor, physicians who see you, a surgeon who sees you who has experience in this, will be able to get a good sense of that right from the beginning. Usually if we see things on the endoscopy report, like this is a 5-centimeter ulcerated mass, someone says, they were admitted to the hospital and had a blood transfusion because there was sudden bleeding from the tumor. Those are all signs that this is a middle stage tumor and we don't need to do this extra test. But for people who have these kind of findings, we do recommend moving on with things like PET scan. The PET scan is to make sure that we don't have other spots that we couldn't otherwise see that have spread. You don't need that for early stage cancers, but for middle you do, because there's a high risk that it could possibly have spread. We always recommend a diagnostic laparoscopy, and that's an important study that will test that we'll talk. I'll show you more details about what that means. But this is a way for us to be sure that you don't actually have later stage disease. And you might say, well, we don't want to know about it. We don't want to find it. But the truth is, it's incredibly important to know this before we begin treatment, because we can tailor our treatment better to help you if we have a very accurate understanding of the stage. Tumor markers, like we talked about, these special markers, MSI and EBV, these are things that say, hey, maybe you'd be a good candidate for immunotherapy. PD-L1 also to a degree, but that's a little bit more complicated. And HER2, there is a subset of patients, especially GE junction, about 15% of patients who will have HER2 expression and therefore would be candidates for another type of medication called trastuzumab. So these are all things that we really need to sort out for middle stage tumors. This laparoscopy that we do is done to see that you don't actually have later stage disease. If you do, that's the medical oncologists take things over from there. But if it's a locally advanced tumor, then we check to be sure that you don't have an MSI high tumor. If you do have this special subtype that is more responsive to immunotherapy, those patients go right to stomach surgery. They go right to gastrectomy with lymphadenectomy. Because in this subset at MSK, we have found that these patients don't respond well to conventional chemo. They just need the tumor out and then immunotherapy and other treatments afterwards as indicated. For patients who have any other type of cancer, then they undergo chemotherapy. And I think most patients will, have a good understanding of that. The neoadjuvant FLOT, that's the standard of care chemotherapy. Why do we do the laparoscopy? Basically because when we are looking inside the abdomen to collect fluid samples and see whether or not these are cancer cells are present outside of the stomach, but in the lining of the abdomen, we do know that's a very strong predictor of how you'll do. And it's really a surrogate to tell us if it's stage 4 disease or locally advanced. So positive disease, if you do have positive cytology, this is an older paper, by the way, this is 2005. We now know that when patients have positive cytology, we are lengthening this curve significantly. It still is considered stage 4 disease, but we do have some options for people who have stage 4 disease, and we are able to keep those patients alive much longer, sometimes, in some cases, which we can talk about even doing a gastrectomy, depending on how they do and how many years they are dealing with the chemotherapy. Go on behind here. The laparoscopy with the positive cytology is classified as M1 in the AJCC Cancer Staging Manual, which is one of our main guidelines. as well as the NCCN guidelines. This is also included with M1 disease, just so that you have an understanding of what that means. So there we go with that. So this is what a standard pathology report looks like in terms of biomarkers for stomach cancer. And you can see here that MSI status, this is sometimes called mismatch repair proteins or MMR. There are these different proteins that are looked for. In this case, this patient has all of these proteins intact, so it wouldn't be an MSI high tumor. HER2 is another one that is looked for, PD-L1 expression, and EBV. So these are the kind of things that we're looking for. So you might say, well, for someone who has middle stage stomach cancer, why would you, if they're not MSI, why would you give chemotherapy before surgery anyway? Why not just go straight to surgery? And that's a very common question I get. And the main reason for that is it's the micrometastatic disease that we're aiming to get. So as surgeons, we can go in and remove part of the stomach. We can remove the lymph nodes surrounding the stomach, and we can do that at any time. But the danger to patients with middle stage disease is that microscopically, there are these escapee cells, these little red dots that I've tried to represent here. And these escapee cells are too small to be picked up on a CAT scan or on a PET scan. They're the kind of cells that really you don't know if they're there or not, but we do have good statistics to tell us that they're very likely to be there. And giving chemotherapy allows this therapy to circulate so that we can try and kill off any of these cells before they have a chance to start growing in the lung or the liver or other areas or in the bone. After that cleanup, so to speak, is done systemically, then we can go in and remove what's left of the tumor in the stomach and the surrounding lymph nodes. But this is the most effective strategy. There are lots of randomized trials that have been published that demonstrate that this is the best and most effective way, and it improves the chance of survival anywhere from 10 to 15%. So now in terms of the surgery, what kind of surgery is the best? I do minimally invasive surgery. When I started at Sloan Kettering in 2005, I started doing laparoscopic gastrectomies. The robot has become an incredible tool that has helped to kind of even push the envelope of what we can do laparoscopically. So I now do almost all my cases robotically. But when you think about it, the minimally invasive approach is a fairly new approach. Only 1994 was the first laparoscopic gastric resection that was reported by a surgeon in Japan. Then in the early 2000s, there were a number of smaller trials, both from this group in Italy and then some others in Korea and Japan, all of which demonstrated that it's very safe to remove your tumor laparoscopically. The minimally invasive approach is safe, and you're not risking a cancer cure because you're doing it with little incisions. Then 2019, just in the last few years here, very large randomized trials, 1,000 patients, almost 1,000 patients in each of these two studies from a Korean group, actually a whole group of hospitals in Korea, and the Japanese group. They very carefully demonstrated that for early gastric cancers, a laparoscopic approach and an open approach are the same in terms of giving you a good cancer outcome. In addition, the minimally invasive approach has a lot of benefits: decreased length of stay, and all other, less blood loss, quicker recovery, and so forth. You might say, well, what about more advanced gastric cancers? Because that's what we see in the United States. There are now 4 randomized trials that have looked at advanced gastric cancers compared to lap versus open approaches, also demonstrating that the cancer outcomes are the same. Your chance of getting cured is the same if you're having a minimally invasive approach done by someone who is experienced, a high-volume gastric surgeon who knows how to do a laparoscopic gastrectomy with lymph node dissection. There's this study from China called the Chinese laparoscopic group, this Japanese study, another study from the Korean group. They're very, very experienced with this in Korea. And then the stomach study, this is a randomized trial from the Netherlands, actually, so it's the only Western study, looking at lap versus open total gastrectomy. But all of these studies just support this approach as being a safe and good approach. You might say, well, that's laparoscopic. What about the robot? Many patients will ask me that question also. Laparoscopic and robotic approaches, in my mind, are essentially very similar. It's the same incisions. You're doing it with minimally invasive surgery. It's just the equipment and the machinery is different. The robot is a bit of a fancier machine, so to speak, which allows you to do things a little bit more easily and smoothly. But laparoscopic approaches are also solid and very good for someone who has experience with them. And it's the same incisions, it's the same idea. It's just the machinery is a little bit different. But the randomized trials looking at robot versus laparoscopic approaches suggest that maybe there are even fewer complications that we see after robotic gastrectomy. In addition to maybe better lymph node dissection, the camera is really very, very nice and you can see well. So there are a lot of benefits. And most importantly, with a minimally invasive approach, there is a chance that you can get back to recovery. You can recover faster and begin chemo that you need more quickly. As you know, stomach surgery is not an easy thing to go through. And some people have complications afterwards or have some trouble with the recovery. And what we really don't want is to have patients have trouble recovering so that they can't begin their chemo, because we know that the clock is ticking and it's important to get the chemo started. But some people just aren't doing well enough. The minimally invasive approach may help that. Our group at MSK published our insights in outcomes for patients, about 220 patients who underwent robotic surgery, and we had some discussion here about learning curve and selection criteria. We know that not everyone can have a minimally invasive approach. The most important factors are if you've had chemo before surgery, that decreases your likelihood of being able to have it done robotically in some cases. If you're very overweight with a BMI over 37, so the more obese patients, it can be difficult to do certain types of gastric surgery. And if the tumor is really big or bulky. So not everyone is good for this approach, but that helps to answer the question that I get quite a bit. So minimally invasive approaches are very helpful. They can decrease hospital stay, less blood loss. As a patient, you get back to your work and your life sooner. And that's ultimately what we really want here, is to improve your life, make sure that you can get back to work and go back to having as normal a life as possible, as quickly as possible. Now, in terms of receiving the chemotherapy, our group published a study that demonstrated that, yes, in fact, if the minimally invasive approach was used, laparoscopic or robotic, in this case it was laparoscopic, stage for stage, when patients needed to get chemo, if they had the minimally invasive approach, more of those patients went on to get chemotherapy, which they needed, than the patients who didn't. There's a big randomized trial from China. This one was published just in 2021, which actually found the same thing with robotic versus laparoscopic approaches. So overall, it's a good thing. So I thought that what we could do now, I'll just ask Brittany if we want to stop for any questions or just go right into the case presentation, which may be helpful. Brittany?
Well, we have one question, so if you'd like to answer that, and then after that, we can get started with the case presentations.
Sure.
So one question came in from Eba, and it says, why does having chemo before surgery decrease chance of robotic surgery?
Oh, yeah, so that's a great question. So the reason is that chemotherapy, so when you start with a tumor that's in the middle stage, it tends to be a bigger tumor and a bit more advanced. After chemotherapy will shrink the tumor, but it causes a lot of scar tissue in the area. And in some cases, especially if you have a tumor and enlarged lymph nodes around certain vessels, if that area shrinks but then causes scar around some of the main blood vessels, then doing this robotically, where you can't see where these important blood vessels are, could be dangerous. And so in some cases, you can remove those lymph nodes and keep a person safe better when you're actually in there and can feel it. So that's why the chemotherapy can really interfere with some of the planes that we as surgeons use, and sometimes it's just safer. Ultimately, what I tell patients all the time is my number one goal, no matter what, is to keep you safe and to make sure that we do a good operation, a good cancer operation. So the safety and the highest quality cancer operation, most important thing. The next level is to do it minimally invasively. So if we can do both of those, that's great. But I would never compromise safety or a good cancer operation in order to do a minimally invasive approach, if that makes sense.
Yeah, we also had another question. I don't know if you can answer this. It says, what is the standard of care for stomach cancer reconstruction after a total gastrectomy?
Yeah, okay, so let's get through this case quickly, and then we'll, because I think we only have 22 minutes left, is that right? I'm looking here. Okay, so let's get through the case, because we'll get into some details of reconstruction. So talking about a case, I have this one example, a 61-year-old man who had some medical history, 30-pack year smoking history. Smoking it's always a bad thing. It increases the risk of a bunch of kinds of cancers, especially, stomach cancer. And he was found to have a large ulcerated mass 2 centimeters below the GE junction. So this endoscopy that we're talking about is when this scope is placed into the stomach, right? So it's in the stomach. And then there's an ultrasound probe that's on the end it's a special study so patients usually come in with an endoscopy and biopsy. This is a straightforward, you see the tumor, here's an example of the tumor, and they have a biopsy. And then I'll say, well, we need to do another endoscopy. And they're like, well, I just had an endoscopy, why another one? This special one has an ultrasound probe, as you can see on this right-hand panel here. And that ultrasound gives us these pictures, which I know are hard to interpret, but it tells us if the tumor is superficial or if it's deep into the wall of the stomach. And that helps us to decide if you might be a candidate for maybe not even an operation, but a scooping out, this endoscopic submucosal dissection, or if you do need an actual operation and chemo. The other thing we look at is the CAT scan. The CAT scan here, you can see I've demonstrated an area where this tumor is involved sorry about that. So you can see some thickening of the wall of the stomach here, and that's a sign of somebody who has a more locally advanced tumor. The other thing we look at on scan is whether or not you have lymph nodes that are enlarged. So here you can see some visible lymph nodes. And again, these are things that give us a sense that this is not an early stomach cancer. So we go back here. When we think someone has a middle stage cancer, we'll also get the PET scan. Why do we need those? This is just reinforcing that point. You can see this bright area here that lights up where the cancer is. PET scans light up in areas that are cancer, inflammation, or infection. So there are different things. This is not the patient we're talking about, but you can see how we would not be able to see, for example, a large lymph node that's up in the chest area. This is the area in the stomach, but you would not be able to see that without a PET scan. Same way here, this is the main tumor here, the big ball here is the main tumor. And then you can see in the middle of the liver, this bright spot. And that bright spot was cancer in this particular patient. So that's why this test is helpful. Now, for middle stage tumors, like we talked about, diagnostic laparoscopy is important. And I promised that we would discuss what that is a little more. First of all, the reason we do it is for staging purposes, right? We need it for staging. And let me just go back to this. So what it involves is a procedure in the operating room, same day you come in, 20 minutes in the operating room, you go home the same day. But this camera is placed through a teeny little incision in the belly button so that we can actually look around the area. So not the stomach, but look at the abdominal cavity. And we're looking to see if there are any other spots of cancer that have spread. So it is important. You might say, well, the CAT scan didn't show it, but this is an example and a view from inside someone's abdomen. One of my patients who had stage 4 stomach cancer, very sadly. And you can see here, there's some sign of the tumor here. You see this sort of white area here where the stomach cancer is, but you see these little spots over the lining that's away from the stomach. This is the stomach, this is the liver here, but you see these little spots, and these are all cancer. And this is very important to know before we start chemo, okay? It's the kind of thing that is not shown on CAT scan. This person's CAT scan said everything is fine. They just see the tumor in the stomach, but they can't see things this small, and that's why this test is so important. Luckily for the patient that we're discussing, all of the washings, the fluid samples that we had showed no signs of cancer cells, so that diagnostic laparoscopy was clear. He had an infiltrating cancer, moderately differentiated, ultrasonic, that's what the U stands for, T3N1. So these are all signs to us that this is a middle stage tumor. Next steps in treatment. So chemotherapy with the 4 cycles of FLOT, as we had talked about, in order to kill any micrometastatic disease. And you might say, well, why do we need to do this? This is a very large randomized trial. It's called the MAGIC trial. And it demonstrated that when patients had surgery alone for stomach cancer, this is what their survival was. But these are for locally advanced cancers. With the addition of chemotherapy, 13% better improvement in survival, 13%, and these were matched patients. Then the more recent study, the FLOT study from 2019, compared the standard chemo, in other words, the chemo that was used in this study that's a little bit older, versus the new and improved chemo, the FLOT, and found that there was a 9% improvement in survival over what this chemo regimen was able to provide. So this changed practice overnight, and this is why we use FLOT. But it definitely improves our ability to cure you. In this case, the patient had a good response to chemo, and now everything looks good. The PET scan showed improvement. Time for surgery. So let's get on to the surgery. Robotic total gastrectomy with Roux-en-Y reconstruction. We'll talk about this. First of all, you can live a normal and good life without a stomach. This was an article from the Wall Street Journal from just a few years ago, which looked at CDH1 mutation, a special genetic mutation that requires us, when found and with a family history, to remove the entire stomach of the patient. Not every patient, I want to be careful to say, not every patient needs total gastrectomy, but many patients do. This is a father-daughter couple here that were highlighted in this Wall Street Journal article that you can look up. This was my patient, and both of them were my patients. And you can see this is a year after her gastrectomy and 2 years after her father's gastrectomy. They're doing well, working full-time. This is another group of patients who had this mutation. None of the people pictured in here have a stomach. They're all after their total gastrectomy. So there are some changes. That's a whole other hour-long talk about total gastrectomy, but you can go on to live a good, healthy life without a stomach. At MSK, we have a lot of experience with hereditary diffuse gastric cancer or the CDH1 mutation. We specifically published an article just looking at things that patients want to know. What happens with postoperative outcomes, weight loss? We were able to find that most people, although they do lose weight, this is like at 6 months or more after surgery, you see a dark gray bar, which is their weight before surgery, paired with a light gray bar that shows their weight after surgery, 6 months or further out. And you can see that almost everyone maintains what we call a normal weight. There are some people, in fact, who are very obese who still remained obese, but they did lose weight. But nobody really went to a point where they felt uncomfortably underweight. There were only a couple patients that were sort of hovering around this line. This one lady was was very underweight to begin with, but her weight barely budged after gastrectomy. But this helps to give people some reassurance that you're not going to, you'll be able to look normal, to feel relatively normal after this. In fact, 85% of patients said that they had outcomes as or better than they expected. And although many people, almost half, said that they did have to modify how they ate, including avoiding certain foods, carbonated drinks, so forth. At our center, we have a whole team that is coordinated around helping people with total gastrectomy. So, for example, we have a team of nutritionists who have specially arranged a plan with us to meet with people before surgery, during surgery, when they're in the hospital, and then every couple weeks after surgery until they get on their feet and really understand how to eat well. So having that whole team to kind of embrace someone after they've had gastrectomy, it's not like we're going to operate and then you have to figure it out on your own. It's important to be at a place where you have this whole team that is going to embrace you, make sure that we get you through any of the bumps that might happen after surgery. But anyway, all the patients who were working before surgery returned to full-time work in this series. Now, getting to the other person's question about reconstruction, robotic total gastrectomy is required in some cases. We do it with the D2 lymphadenectomy, like we had talked about. And let me see if it's, there we go. Here's a picture which shows you these famous lymph nodes that people don't really understand so well. So this is a picture intraoperatively of the stomach. Here are some blood vessels that are feeding blood supply to the stomach. And you can see this instrument, this robotic instrument, is right underneath this little tan structure. I hope you all can see it. But this is a lymph node. That's what these lymph nodes look like. And they're the drainage stations. So when you have a tumor, the first place the tumors like to spread is they like to drain through these little lymphatics into these lymph nodes. And it's important to remove all of them. There's another lymph node here. There are a few more that I can see here, but this is the most prominent one, just so you mentally have a picture of what that looks like. What about the total gastrectomy? There are new techniques. In some cases, a total gastrectomy is necessary, depending on the tumor. But in some cases, people have GE junction tumors or proximal tumors. So do you really need to remove the entire stomach and do this Roux-en-Y? It would be great if we could save part of the stomach. So this is, again, our robotic outcome. But one of the new novel reconstructive techniques that we have and that we are offering to patients that are selected appropriately at our institution is a proximal gastrectomy with double-track reconstruction. So rather than for a tumor that is right up at the top of the stomach, where the rest of the stomach is normal, rather than giving them a total gastrectomy, there we go, let me get this to fast forward here, we save the bottom part of the stomach, only remove the top part of the stomach that has the cancer in it, do a Roux-en-Y reconstruction as we would here, but then reconnect the bottom half or bottom third of the stomach so that you have these two tracks, double tracks, one here for the food to go down. The most important part is you get to keep some of your stomach. This is a fairly new technique, and it's one that was published first in 2017 by the Korean surgeon group that I know well. They're a very good group. And they reported almost 100 patients for whom they did this procedure compared to the standard classic total gastrectomy. And in that study, they found that patients had less anemia. That means their blood counts didn't drop. They didn't need iron transfusions. No B12 deficiency. So once you have part of your stomach, then vitamin B12 you're able to absorb it, so you don't need to worry about B12. And there was a question about whether patients had improved quality of life. There's an ongoing large trial called the Class 5 trial. There's a randomized trial that was being presented at the IGCC meeting just a month ago, and they are in the process of very carefully figuring out whether or not there's improved quality of life and some other things that might be of an advantage. It'll still be a couple of years till these results come out. Now, other approaches, jejunal interposition. So in some cases, you can also take a piece of intestine and use that as a conduit from the esophagus to the bottom part of the stomach and spare the bottom part. That's something else that we do selectively at our institution for certain cases. And for patients who do need to have their whole stomach removed, we can do what's called a pouch, a gastric pouch. And this is a jejunal pouch reconstruction. So there are different options to answer the question of that one patient that we have for reconstructing. And I can't tell you that one size fits all. That's why you need a surgeon who's comfortable and familiar with all of these approaches and can talk with you about which approach is right for your particular cancer. Because again, quality of life is very important, but we need to make sure that we do the right cancer operation. That's the most important thing. Here's a close-up view of the jejunal interposition. Take a piece of intestine here, connect it from the esophagus down to the rest of the stomach. So anyway, to finish up this case and take a few questions, this patient had an invasive cancer. We were able to get all of the cancer out. The margins were negative. And there was a downstaging because this patient had chemo beforehand. So they started as a stage 3A stomach cancer clinically. That's what the C stands for, clinically, stage 3A. After chemo, everything shrinks. So you get downstage to a stage 1B. That doesn't mean this person had a stage 1B cancer. They were downstaged, which is certainly a good thing, but it's not quite the same. So that's one problem when you have chemo beforehand, and had a 50% treatment response, which is great. The downstaging definitely helps. This is
I'm sorry, Dr. Strong, we can't hear you. No, unfortunately, I still can't hear you.
Hi there. Can you hear me now?
Yes, perfect. Thank you so much.
Okay. How much of that did you not hear?
You were talking about the staging at the top, I think stage 1B.
Okay. Just this slide. Just the slide.
It's the slide.
Okay. Not half the talk.
No. I caught it as soon as we stopped hearing you.
Okay. Sorry about that. So this particular patient, he was downstage. So started as a clinical stage 3A, where you can see what survival statistics are. After the neoadjuvant chemo, he was downstage. So you can see how much this chemo is projected to have helped this patient. So really worthwhile. I think we are almost set here. Let me just see. So 3 weeks after this operation, patient returned to medical oncology because he had a minimally invasive approach. He was ready to go 3 weeks later, received 4 more cycles of FLOT, and currently, actually, he's now at 2.5 years with no signs of recurrence. So it's good news. So the take-home points are that chemotherapy for middle stage tumors is safe. It definitely improves survival. The minimally invasive approaches, whether robotic or laparoscopic, as long as they're done by a high volume surgeon who understands the principles, provides equivalent cancer operations to the open. And quality of life is good. Even if you have a total gastrectomy, Total gastrectomy is the one area where there is more support required. But if you go to a place that has a good infrastructure and a nice support system in place, we can get you through that, and you'll go on to have a good life. So thank you very much. I know we only have a few minutes for questions, but I hope this was helpful. I hope it was not too much detail, but I know that the patients today are very sophisticated and they do a lot of reading. And so they really want to know the details about why the treatment is being done the way it is.
Thank you so much, Dr. Strong, for sharing so much of your expertise with us today. We have received some questions during the presentation, so I'd like to take a few minutes to ask these questions in our remaining time. And I'll start with, let's see, this person says, can anything be done to reduce chances of recurrence after treatment?
Such a great question. I know, because once you've been through something as traumatic as this, that's the big fear. The short answer to that is not really. I mean, other than having a healthy lifestyle, meaning no smoking, don't smoke ever, because it causes so many types of cancers. But other than that, and trying to eat a reasonably healthy diet, there's no specific way that you can prevent this from coming back. In fact, most of the time, about 50% of the time, we think that the reason people get stomach cancers, because that's a common question I get, why did I get this? What happened? Unless you have a genetic predisposition. But if you don't, people are always asking, what happened? What did I do wrong? It can happen as just half the time it's just bad luck. Bad luck. There's a failure in the ability of your body to clear out, a cell that's gone rogue, and these cancers can develop. So it's not something that you can prevent happening, and I don't think that there is any good way that you can prevent it coming back, short of not doing bad things like smoking.
Thank you. Another patient asked, another attendee asked that this patient that had a neoadjuvant, did he still go through robotic surgery?
Yes, he did. Yes, a robotic total. So the reason I brought up that point is that when people come in, sometimes they get focused on, they get very focused on having a procedure done robotically. And I love doing robotic surgery. That was my training, and I'm very committed to it. But I also know that not everyone is the right candidate for a robotic approach. So sometimes when I see patients, they're very focused on having it done robotically. And I say, well, let's really look at the most important thing is we want you to be cancer-free. We want you to be cured and to live and have a good, healthy life. And that is more important than the size of the incision. And that's coming from me, a robotic surgeon who loves robotic surgery. But, more important than the approach is the cancer and making sure that we do the right cancer operation. So it's just, I'm trying to help put that into perspective. So I hope that helps.
Yeah. So another question, this is a 10-year survivor after robotic surgery, total gastrectomy without adjuvant chemo due to complication of serious stricture. So the question is, will the anastomosis and esophagus deteriorate over time due to reflux floating up and down the digestive tract?
So it sounds like this person had a total First of all, congratulations. At the 10-year mark, that's incredible, and I'm very happy that you didn't need to get additional treatment. It sounds like this patient had radiation, though, you said? Is that what I heard?
This person had robotic surgery, total gastrectomy without adjuvant chemo.
Okay, not radiation. Okay. So no, I don't think that having that kind of reconstruction does not put you at increased risk for developing another cancer in the future, because people get worried about the loss of the valve at the top. That's not an issue, because the way the reconstruction is done, the bile and the bile juices can't climb up quite that high. So that is not something that you typically need to be worried about.
Thank you.
Congratulations to that person, by the way.
Yes, congratulations. And then we just had another question. Are there any latest surgical advances for stage 4 CM1 patient whose greatest tumor burden is peritoneal mets, who has had a deep response to systemic therapy?
So for stage 4 patients. So yeah, these are the ones that we need to do more work on. And I have a very close collaboration at our center. We have a whole laboratory, translational laboratory, in which we are really actively and very aggressively trying to find better treatments for patients, both locally advanced patients and stage 4 patients. We're trying to really understand the immune system, the microbiome, and how that works together. So we're doing a lot of research, which is promising, but it's still a few years away. If we could accelerate it, it would be great. So that's why groups like Debbie's Dream Foundation and others can really help in terms of raising awareness and also raising funds to move this research forward. For stage 4 cancer, there are a few trials that are ongoing, like HIPEC is a common question that I get. There are three clinical trials that are ongoing in the United States. I would strongly recommend that people stay away from small centers who say they'll try something but not on clinical trial, because I think if you are going to investigate something, you want to do it at a major center that really has expertise and has a very sequential and very rigorous way of looking at treatments and what the outcomes are so that they can keep you safe. But there are new things, especially immunotherapy, which we didn't have time to get into in this talk, is a potential game changer for patients who have stage 4 stomach cancer. Not everyone is a candidate for the immunotherapy, but you have to talk to your medical oncologist. But there are new types of immunotherapy that are coming on the market. Those immunotherapies combined with chemotherapies, we're seeing some things for stage 4 patients that we've never seen before. We used to think that stage 4 is really not curable, just something we can slow down. But immunotherapy has been changing the landscape. So it is very hopeful, even for patients with stage 4 cancer, that we are developing new medications, new approaches that will continue to push this forward. I think that the key thing is, like you mentioned in the beginning, Brittany, is raising that awareness and getting more funding. That's what we need. There are several big research centers like ours in the United States, and we just need more support to really move this research ahead faster. Like we want to move it ahead. We just need to get enough people interested and enough funding so that we can accelerate this. That's my goal. And that's the goal of the team that we have at MSK, as well as some other big centers in the U.S. So.
Thank you so much. Just another quick question, and then we're gonna wrap up. But just to correct, okay, I'm sorry. This person says, do you decide to go for robotic surgery based on PET scan after neoadjuvant?
No, the PET scan doesn't really determine it. It has more to do with a few factors, like, the size of the tumor, what it looks like endoscopically after treatment, and also what it looks like at the time of surgery. So the PET scan doesn't necessarily make or break that approach.
And is the cancer grade important for prognosis?
It is, yeah. There are several factors, things like lymphovascular invasion, the number of lymph nodes, the stage of the tumor, the treatment response. All of these things are very important. And we put it together. Actually, at MSK, we have a nomogram. It's something it's open to the public, where you go online and you can actually put in certain factors of your gastric cancer, your age, your grade, your lymph nodes, and it helps give you some survival statistics. I'd be very careful with that, because I will tell you that when you look at these numbers, that's not including the more recent advent of immunotherapy in the past few years, which has, like I said, changed the landscape of what we're able to do for patients, even with later stage stomach cancer. So, take all of these things with a grain of salt. But there are a lot of great tools out there that can be helpful, to answer some of those questions. But again, it's really in the research and moving ahead this incredible area, especially with immunotherapy. I think that really will give hope and better treatments to all of you. And ultimately that's the goal, of surgeons and physicians at places like MSK or other cancer centers. We're obsessed with how we can improve stomach cancer treatment and how we can get more of you cured. That is what we do nights and weekends. That's what we're devoted to. And so hopefully we'll be able to do that. We're working for you guys. We're trying our very best, and we're going to do it.
Efforts. Just so you know, that patient that you congratulated for 10 years as Nelson and Patricia Savello, he said that you were his surgeon. So congratulations to you also.
Oh my gosh. It's great to have you guys here. What a happy thing to hear. I love it.
Well, that concludes.
I look forward to seeing you guys.
Yeah, that's awesome. That's awesome. We're glad that they can join us as well. Unfortunately, that concludes our time, so we're out of time for questions. But Dr. Strong, thank you so much again for joining us and for sharing your expertise. We appreciate you always. And I just wanted to share to please visit the DDF website for some of our upcoming events and programs as listed here. And that pretty much concludes today's presentation. We'd like to thank our generous sponsors that are featured here. We especially like to thank Dr. Strong for taking time out of her busy schedule to present for us today. And just a reminder, to view any of our recorded webinars, you can visit our website on the lecture library at www.debbiestream.org. And that concludes today's presentation. Thank you so much, everyone, for tuning in.
Thank you. And thanks, Brittany, for putting this all together. You did a wonderful job.
Thank you. Until next time.
Bye-bye, everyone.
Bye.